So the next infection is mastitis, which is the infection of the breast. So these patients come in usually with acute onset of fever, breast pain, and usually it's followed by engorgement. So these moms can be breastfeeding and now they have engorgement, and then they develop fever and breast pain, and it can be unilateral or bilateral. So there is no need to do any labs or tests. It is mostly a clinical diagnosis, but you can culture the milk and then find out the exact bacteria. Most of the time these infections are going to be staph infections, and sometimes these can even be resistant staph or MRSA. Treatment would be the treatment of choice, so the drug of choice is dicloxacillin, which covers MRSA, and then you can also give cephalosporins or trimethoprim, sulfamethoxazole, which is Bactrim, and then vancomycin in severe cases. This is a slide showing just an engorged erythematous tender breast, so it's mastitis. And then the next is cholecystitis. So now we are coming below the diaphragm, and you can see there is going to be a change in pattern. So different kind of group of bacteria are going to start causing infections now. So cholecystitis is the infection of the gallbladder. These patients usually have a very acute onset of fever and right upper quadrant pain, and they also have vomiting. So these three symptoms, when present, especially postprandially, specifically when they say, okay, after I ate, then I had pain, and then also I threw up, on top of that they have fever. Now it should make you think that maybe it is cholecystitis. So there is a common understanding. People think that female overweight 40 patients in their 40s, and then fertile females, they are the ones who are more at risk for cholecystitis. But remember that there are no absolute rules in medicine, so anybody can present with this. On exam, there is a positive Murphy sign, which means that when you palpate right upper quadrant, it will elicit tenderness, and then generally that entire quadrant can also be tender. The diagnostic test of choice is ultrasound. So ultrasound will determine if there is cholecystitis or not. It is a very helpful test. It can also show if there is any gallstone, which will basically mean cholelithiasis, with the similar picture, except that they don't have fever usually necessarily. So complete blood count can also be done to see if there is what is the extent of the infection, and then of course to monitor treatment. There can be two kinds of cholecystitis. There can be inflammation without infection, giving the same picture, or there can be inflammation with infection. So whenever there is infection, it is usually the gram-positive rods, and that's what you're going to start seeing more overwhelmingly below the diaphragm. So E. coli and Klebsiella infections are the most common bacteria that will cause cholecystitis, and naturally the treatment would be directed against them. So you will, instead of using your old garden variety antibiotics, you will now use ampicillin and sulbactam, piperacillin and tazobactam, or ceftriaxone and metronidazole. So these are combinations that can be used, and most of the time you have to do IV antibiotics because these people cannot remember keep anything down. This is a slide showing just an ultrasound picture, so just kind of to give you an idea. There's some inflammation of the gallbladder wall and some dilatation, and then there is some Doppler here. What is acute cholangitis? So that is the infection of the duct. So this is very similar to acute cholecystitis. The only difference is now there is blockage. So now you're going to see jaundice. So whenever jaundice is present with fever and right upper quadrant pain, that is called Charcot triad. So whenever you have you have these three symptoms present, then definitely think about Charcot triad. Definitely try to rule out or rule in acute cholangitis. The diagnostic test of choice again will be ultrasound, and then you can do liver enzymes to see what is the extent of the damage, if the liver is involved or not. And then ERCP and MRCP are most commonly used to look for any obstruction there. The bacteria again will be your infamous gram-negative rod, E. coli, Klebsiella, and then there can be some Enterobacter, Enterococcus, and anaerobes. So anaerobes is another category of organisms that can be involved here, and treatment should basically cover this category. So again, the same three combinations of drugs, and then you can drain also. If there is an abscess formed, you can put a J tube, and then it will drain the abscess. Here is a slide showing the MRCP, so you can see some inflammation and obstruction. And then the next is acute viral hepatitis. So this is also very similar to acute cholangitis or acute cholecystitis, in the sense that it is the right upper quadrant pain. So whenever you have right upper quadrant pain with fever, now there are three different possibilities. There is acute viral hepatitis, acute cholangitis, or cystitis. But the difference would be that this is usually virus. So remember, infection is going to be more subacute or indolent. There's going to be a lot of other constellation of symptoms. So people are tired, they're malaise, they have jaundice, pruritus, dark urine, light stool, and hepatomegaly. And this is all happening because of hepatitis virus A. So I'm not talking about B and C, because those don't really cause jaundice. So it's either A or D. And good news is, or at least for us, is that hepatitis A is not very common in this part of the world. So the incubation period is 30 days. So if a patient has already traveled to an endemic country where hepatitis A is common, then, and they've come back within 30 days, they start to develop, or after 30 days they start to develop these symptoms, then we can consider this diagnosis. Otherwise, we don't really see it that often. Also, you can see there are quite a few very specific symptoms like urine and stool color, which will point you to the direction of hepatitis A as opposed to other two problems. Treatment, again, it is a virus, so it will be a supportive treatment, and we just make sure that it is not spreading to other people, because the route of transmission for this virus is fecal-oral route. So it's not a parenteral route, it's not through sex, it's through fecal-oral route. So we just need to make sure that we explain that to the patients. Here's a slide showing the serology. So when do the antibodies and antigens start to appear? So within the first week or two, you will start to see that hepatitis A virus antigen will be present in the stool. Then viremia will be present in the blood, so you can actually culture the virus. But then within 2 weeks also, you will see IgM antibody, which is the antibody, acute antibody to the virus, will start to rise, and then will start to level off and then finally drop. ALT, which is a liver enzyme along with the AST, will start to rise. IgG antibody, however, which is a chronic antibody, will only start to appear after 2 weeks have passed. So if a patient shows up and less than 2 weeks of illness have passed and they show IgG antibody to hepatitis A, then it's not hepatitis A causing these symptoms, because their symptoms should have had occurred more than 2 weeks ago. Then it's either that they had hepatitis A infection in the past and now they have a new problem, or maybe they were vaccinated against hepatitis A virus. So just keep that in mind. Next is infection of the colon. So again, this is infectious colitis. A lot of the times people use gastroenteritis synonymously with infectious colitis, but gastroenteritis typically is a virus infection. So in this talk, I'm talking about bacterial infections, or infections that are causing fever mostly. So this is going to be more focused on all those infectious colitis that are usually bacterial. So these guys will cause fever, diarrhea, which is mostly bloody diarrhea a lot of the times. They have generalized diffuse abdominal pain and nausea and vomiting. So that's how patients present. They usually have a few days of illness, so usually not as dramatic as 24 hours, but 3 to 4 days. And sometimes people wait for almost a week, because a lot of the times people think that it's a virus and will go away, but it just doesn't go away, and diarrhea just starts to turn bloody and they start to develop fever. So that's how they present. And the bacteria are basically these organisms, and then these are the just kind of the key features along with each bacteria separately. So Salmonella is going to be more present with a history of eggs and poultry usage. Shigella is usually mediated through Shiga toxin, so that's how they develop dysentery, and that's how they develop high-grade fevers. E. coli, our infamous old friend. E. coli is a pretty bad bacteria that with specifically this one strain O15787, which is going to stay with you, I think, forever, because it causes so many problems, will cause not only infectious colitis, but now complications, for example, hemolytic uremic syndrome. And then enteroinvasive strain of E. coli will also cause pretty bad infectious colitis. And there is a protozoan, for example, Entamoeba histolytica. It is very mild. Usually it doesn't cause too many symptoms, but the important thing to remember about this is that it's a protozoan, it's amoebic, so it causes liver abscess. So if we ever find that this is present, we should treat it, because otherwise patients can get a lot of complications. Next is Campylobacter. This is different in the sense that it causes prolonged duration of symptoms. So usually patients have more than 2-week duration of diarrhea, and then the bacteria are comma shaped or S shaped. C. diff colitis is extremely important because this is a very special kind of bacteria. It starts to flourish in the presence of antibiotics. So this is unique about it. So people will take antibiotics. For example, most common antibiotics are penicillins and cephalosporins or clindamycin. When they take these antibiotics for whatever reason, for example, pneumonia or tooth infection or whatever, these people then allow the growth of C. diff or Clostridium difficile in the bowel, and that causes pretty bad bloody diarrhea with fever. So these are the things that we must keep in mind. Treatment is going to be, of course, directed toward all these organisms. So fluoroquinolones or ciprofloxacin is going to be your drug of choice for vast majority of these, except for macrolide antibiotics or azithromycin can cover some E. coli as well. Vancomycin is going to be necessary for C. diff colitis, because Clostridium difficile is not going to be responsive to the fluoroquinolones. And then metronidazole is necessary for Entamoeba histolytica, because it's a protozoan. Another thing very important thing to keep in mind is that vancomycin should be given orally if you're suspecting C. diff colitis. So this is the only one scenario where we don't use vancomycin intravenously, because the patient has intestinal infection, so you don't need to really go the other way around. You just need to do direct oral dose of antibiotic. So vancomycin would be oral. In very mild cases of C. diff colitis, metronidazole can also be given, and it will work, but usually we just use vancomycin. The next is appendicitis. So these patients are going to be your young guys, so young children coming in with fever. Usually it's within 24 hours that they show up. So they come in with acute low grade or high grade fever with right lower quadrant pain. And then they also have nausea and lack of appetite. Lack of appetite is one of the most important features that these people have, because very young children, for example 2 or 3 years old, they don't really complain about right lower quadrant pain. They can't really verbalize that, so they just stop eating, and they have nausea, usually not very much vomiting, and that's how they show up. So in a sense, it's fortunate that they develop fever, because if they didn't have fever, we would probably not be able to pick these diagnoses. So we will miss this diagnosis quite a bit. So anyhow, they show up with these symptoms, and then on exam, your McBurney point will be positive, which everybody knows where it is, in the right lower quadrant. And then if you palpate or deeply palpate the left lower quadrant, then there will be tenderness in the right lower quadrant. And basically the pathophysiology behind that is that now the appendix is inflamed the surrounding peritoneum, so there is peritoneal inflammation or inflammation of the peritoneum that's causing tenderness or rebound tenderness. Labs and tests to do would be urinalysis can be done. It will show some white blood cells, but not your regular leukocyte esterases and nitrites necessarily. So this is important to keep in mind, but because it can become very distracting, because UTIs are quite common in children, especially female children. So if you see pyuria with fever, don't just get distracted. And I've seen this mistake be made by many people, that people just treat for UTI because they say, okay, there is fever, there's some pyuria, so let me go ahead and treat them with antibiotics for UTI. But instead, in fact, it is appendicitis. So always make sure, the take-home message is, make sure that you are doing the abdominal exam. And when you see or you can elicit tenderness, then definitely you got to rule out appendicitis. So CBC will be helpful, but it's not diagnostic. It will show leukocytosis, and the most important test is CT scan. So CT scan will basically rule in or rule out appendicitis. In cases where you cannot do CT scan, for example, when a patient is pregnant or radiation cannot be given, you can do ultrasound. It will also give you quite a bit idea. Treatment is surgery. Surgery is the treatment of choice for appendicitis, but recently some studies have shown that antibiotics can also be given, and these people can be washed as opposed to being taken to the operating room. So the next is, we're going down the list. So next is pyelonephritis. So pyelonephritis, as the name suggests, is the infection of the kidneys, and it can be a contiguous infection starting from the bladder and then send up to the kidney, or it can just be a standalone kidney infection. Patients present with these symptoms. Most of the time these symptoms are present, which is again a good thing, because that's how we know that this is pyelo. So they should have dysuria, pain, difficulty, frequency, and urgency with urination. Those are the symptoms must be present. If these are the only symptoms, then maybe it is just a simple UTI or a bladder infection, and they may have some suprapubic tenderness. But with that simple infection, people don't usually have fever. So now when they start to develop flank pain and fever, then you start thinking, okay, maybe it is pyelo. On exam, they have flank tenderness a lot of the times, and so that's why it's important to examine. And then they can also have vomiting. So again, you can see vomiting can be an underlying, a common feature in many different diagnoses. So don't get distracted by this and think that, oh, it is just a gastrointestinal problem. Diagnosis will rest upon urinalysis. So in the urine, on a quick dipstick, you'll see leukocyte esterases and nitrites. And then if that is coupled with some of these symptoms, then you definitely say, okay, it is a UTI, and you treat them. You don't have to wait for the rest of the tests. CBC can be done to monitor the response to treatment. And then lastly, urine culture can be done, but usually it doesn't come back for 48 hours, so you don't want to wait for the results. Also, regardless, most of the time it will come back with E. coli, so you don't really need that much information because you already know that it's E. coli. Ultrasound or CT scan will need to be done if you're suspecting an abscess. For example, if you've already started to treat somebody and the patient is not getting better, then you can go ahead and do CT scan. But generally speaking, just to make the diagnosis clinically, you do not need to do the CT scan. Again, you can see the most common bacteria, the big E. coli is going to cause it. So regular strains of E. coli will cause a regular pyelonephritis, and they can be treated very easily. But if it is the O157H7 strain, then we are in trouble. The other bacteria that can cause pyelonephritis would be Staph saprophyticus. Usually they are present whenever there is already a stone. So if you already know that the patient has a stone, if the patient is not getting better with regular treatment and you do the CT scan and there is a stone, then maybe this is the bug, Staph saprophyticus. So the antibiotics need to be adjusted. Then some of the less common bacteria would be Proteus and Klebsiella. So make sure that you keep that in mind. Again, these are the same gram-negative rod, so the antibiotic treatment will be very similar. So it doesn't really make a difference in treatment. So again, the treatment depends on whether it is complicated or uncomplicated. So uncomplicated pyelonephritis, like I said earlier, would be just very focal symptoms, not too much fever, no flank or pain or no vomiting. Complicated UTI or complicated pyelonephritis will present with fever and vomiting, and these people usually can't keep anything down, so they need to be hospitalized. So uncomplicated UTIs need treatment with either nitrofurantoin, which is macrobid in the brand name, or trimethoprim sulfamethoxazole, which is Bactrim, or they need fluids, and they need oral fluids, so they don't need intravenous fluids. And then occasionally you need to do ciprofloxacin, especially in patients who have had UTIs in the past and they did not respond to these simple antibiotics. But ciprofloxacin should not be given to very young people, so usually these are going to be your adult patients. Complicated UTIs, on the other hand, the ciprofloxacin is the antibiotic of choice, so keep that in mind. And they will need intravenous fluids because now they are vomiting, and they need hospitalization because you don't want them to develop urosepsis, which is a sepsis of the sepsis because of the pyelonephritis. And very elderly patients, nursing home patients, are very prone to getting urosepsis, so just keep that in mind. This is a slide showing perinephric abscess. So again, if a patient is not getting better, you can see some abscess forming around the kidney. The next is pelvic inflammatory disease. So this is another set of infections that can develop. So basically, this is infection of any one of these structures. So it can be endometritis, the infection of the uterus, or salpingitis of the fallopian tube, or oophorytis of the ovaries. Now, most commonly people just use the term PID or pelvic inflammatory disease and don't use these terms separately, but this basically means the same thing. These people present with a few days of duration of fever. They generally have a lot of lower abdominal or pelvic pain, so keep that in mind. So pelvic pain is definitely going to point you toward this direction. Again, this is going to be your female patients. They have a lot of pain with intercourse. That is a very common finding. They also have vaginal discharge. So if they don't have any vaginal discharge, then maybe either the infection is too high or they don't have PID. They can have some abnormal bleeding, and then on physical exam, and when you do the bimanual exam, they have cervical motion tenderness. The labs and tests to do whenever you are faced with these symptoms or signs, then we'll do the pregnancy test for sure if you're suspecting pregnancy, and if they have a uterus. You can also do PCR or polymerase chain reaction to amplify nucleic acid for the bacteria that may be causing it. You can also do simple vaginal cultures, and then if you are suspecting a complication or an abscess, then a pelvic ultrasound or CT scan will be necessary. But again, just like pyelonephritis and some of the other infections, this imaging is not necessary for simple cases. Etiology. So for the most part, the most common bacteria that cause PID are actually mixed flora, but then sexually active women can also get gonorrhea and chlamydia. So any of these different kinds of bacteria can cause it. Treatment, you can see intravenous cephalosporins will basically cover everything. For just chlamydia, if you're suspecting chlamydia, then you can do intravenous doxycycline, or you can do a combination of these antibiotics. If there is an abscess that has already formed, or if it's not responding to treatment, then you need to drain it. Complications. So this is important. So complications are very important because that is the reason why we make sure we treat PID. So people can get Fish-Hugh-Curtis syndrome. So apparently this was a guy who discovered this combination of complications. So people, these patients can develop hepatic abscess. So basically this just means that the infection spreads to the hepatic capsule and then peritoneum. So that's how they become very, very sick. This is now a widespread infection. So it's called Fish-Hugh-Curtis syndrome. Then it can also develop into an abscess, which we talked about. So these patients will be very sick and will continue to have fever despite antibiotics. And in the long run, they can develop tubal pregnancy. So anybody who has a history of history of PID and now comes in with abnormal bleeding and pain and amenorrhea, you must rule out tubal pregnancy. Another complication is contiguous spread. So for example, if somebody's developed endometritis, they can also develop salpingitis. If they develop oophorytis, they can develop endometritis. So these can spread to one another, and then in the end, the very sad complication is infertility. So these patients may develop infertility and not able to have any children. So this is something to keep in mind. The next is toxic shock syndrome. So this again is not very common anymore because people are more and more aware, and they're not using highly absorbent tampons anymore. But in the past, this was very common, and you are still going to be asked about this in boards, and this will probably stay with you for a while. So make sure that you become familiar with this phenomena. So people come in usually with